Hello, my name is Yenmi and I'm a pharmacist and I enjoy talking about medications and health related topics. And if you'd like to learn about that sort of stuff, then you should stay a while and listen. With that being said, let me go ahead and begin. I like to start off my videos with just a couple of questions, just for some fun. At the end of the video, you should be able to answer all of them. Question number one, what does SPC stand for in hypertension management? A, stroke prevention class, B, single pill combination, C, standard pressure control, or D, sequential pill conversion. Question number two, in acute spontaneous intracerebral hemorrhage with systolic blood pressure between 150 and 220, the guideline supported systolic blood pressure target range is A, less than 120, B, 120 to 129, C, 130 to 140, or D, 160 to 180. And the last question, a patient with acute ischemic stroke is eligible for intravenous thrombolysis. What blood pressure must be achieved before thrombolytic administration? A, less than 220 over 120, B, less than 200 over 110, C, less than 185 over 110, or D, less than 140 over 90. In my last couple of videos, I covered several of the various antihypertensive classes. Today's video will focus on how hypertension should be managed according to the various recommendations from the 2025 hypertension guidelines. I won't cover every single recommendation line by line based on strength of recommendation and quality of evidence, but I'll try to highlight some of the main points. The decision to initiate medication treatment should be based on blood pressure readings and risk. If we look at just blood pressure readings alone, all adults with an average blood pressure of 140 over 90 or higher will benefit from medications. Patients with clinical CVD, which include patients with a history of acute coronary syndromes, angina, stroke, or peripheral artery disease, have an increased risk for CVD events and benefit from starting medications when their blood pressure is 130 over 80 or higher to prevent recurrent events. For patients without a known history of clinical CVD, we look at their medical history to determine if they are at an increased risk for cardiovascular disease events. This includes patients diagnosed with either diabetes, chronic kidney disease, or who have an estimated 10-year cardiovascular disease risk of 7.5% or higher, according to the Prevent Risk Calculator. For these patients, medication therapy is also recommended when average blood pressure readings are 130 over 80 or higher. Remember to keep in mind that the Prevent calculator is used for adults ages 30 to 79 years of age without known cardiovascular disease. Not every patient will fall into one of these higher risk categories. For patients who continue to have average blood pressures of 130 over 80 or higher despite lifestyle interventions for 3 to 6 months, then it's also recommended to initiate medications. If you're asking yourself, what about patients that are younger than 30 years of age? Basically, if average systolic blood pressure is greater than 130, then treatment could be considered after lifestyle modification, but the data is limited. When deciding what medication to place a patient on, an important consideration are the patient's comorbidities and whether they have compelling indications for a specific drug class. Most patients will likely need more than one medication to reach their blood pressure goal, but some patients, such as those with stage 1 hypertension, may only need one agent. For patients with stage 2 hypertension, combination therapy with two first-line medications is recommended. If possible, a single pill combination is preferred because it is more effective, efficient, and consistent in lowering blood pressure and can improve adherence when compared to stepped care therapy. Data from observational studies have found that adults with hypertension on single pill combinations have fewer cardiovascular events and all-cause deaths compared to equivalent multiple pill combinations. Medication adherence is generally better when patients are placed on once daily dosing regimens. For most adults with hypertension, the blood pressure treatment goal is less than 130 over 80. If safe and tolerable, a systolic blood pressure of less than 120 can also be considered. In our diabetic population with hypertension, the goal remains the same. In general, any of the first-line antihypertensive classes can be useful and effective, including thiazide-type diuretics, ACE inhibitors, ARBs, and long-acting dihydropyridine calcium channel blockers. One important consideration in this patient population is that diabetes is the leading cause of chronic kidney disease. ACE inhibitors and ARBs have strong evidence for reducing urinary albumin excretion compared with other antihypertensive classes. Therefore, if a patient is diabetic and has chronic kidney disease defined as an eGFR of less than 60 mL per minute, or albuminuria defined as 30 milligrams of albumin per gram of creatinine or higher, their regimen should include either an ACE inhibitor or an ARB. Patients with less severe chronic kidney disease may also benefit from these classes to help delay the progression of diabetes-related kidney disease. For patients diagnosed with a spontaneous, non-traumatic, acute intracerebral hemorrhage who present within 6 hours of symptom onset with a systolic blood pressure between 150 to 220, data suggests that lowering systolic blood pressure to a range of 130 to 140 and maintaining control for at least 7 days may improve functional outcomes. At the moment, there is a lack of evidence providing which exact antihypertensive medication is best in the first few hours after an ICH. A meta-analysis of 50 studies suggested that calcium channel blockers along with alpha and beta blockers were associated with favorable outcomes compared with RAS blockers and nitrates, but this evidence is not strong enough to establish one preferred class over another. For adults who present with an ICH and a systolic blood pressure of more than 220, blood pressure should be lowered cautiously with careful titration. The goal is smooth, stable, and sustained systolic blood pressure control while avoiding large blood pressure fluctuations and avoiding systolic blood pressures of less than 130 due to potential harm. For patients who present with an acute ischemic stroke, blood pressure control is handled a bit differently because excessive blood pressure lowering can worsen cerebral perfusion. Blood pressure management depends on 4 main factors. Number 1, whether the patient will receive treatment with intravenous thrombolytics. Number 2, whether the patient will undergo endovascular thrombectomy. Number 3, whether the patient has severe hypertension, defined as systolic blood pressure greater than 220 or diastolic blood pressure of 120 or higher. And number 4, whether there is another comorbid condition requiring an urgent blood pressure treatment, such as an acute coronary syndrome, aortic dissection, or acute heart failure. The ideal blood pressure target for these patients is unknown. As a general recommendation, patients who are eligible for intravenous thrombolytics should have their systolic blood pressure lowered to less than 185 and their diastolic blood pressure to less than 110 before given a thrombolytic. After receiving a thrombolytic, blood pressure should be maintained below 180 over 105 for the first 24 hours. For patients undergoing an endovascular thrombectomy, it's suggested to maintain blood pressure at or below 180 over 105 during and for the first 24 hours after the procedure to improve long-term functional outcomes and prevent death. In patients with successful reperfusion, intensive systolic blood pressure lowering below 140 within the first 24 to 72 hours may worsen long-term functional outcomes, so overly aggressive blood pressure reduction should be avoided. For patients with severe hypertension, defined as a systolic blood pressure of 220 or higher or a diastolic of 120 or higher, in the absence of comorbid conditions who will not receive either a thrombolytic or endovascular treatment, rapid blood pressure reductions has not been formally studied, and the benefit in starting or restarting hypertension treatment within the first 48 to 72 hours is unclear. These patients' blood pressure management should be individualized with a suggestion of a 15% blood pressure reduction in the first 24 hours as a goal to avoid excessive blood pressure reductions, which can trigger complications such as stroke progression or acute kidney injury. The guidelines mentions there is no data to show that one strategy to lower blood pressure is better than another after an acute ischemic stroke. Hypertension is the most important modifiable risk factor for stroke and intracerebral hemorrhage recurrence. For patients with a prior stroke or ICH, there is insufficient evidence to recommend a more aggressive blood pressure goal, so their blood pressure goal remains less than 130 over 80. The timing for blood pressure reduction after a stroke is unclear, so the recommendations for secondary stroke prevention pertains to patients who are stable in an outpatient setting. Thiazide diuretics, ACE inhibitors, and ARBs have data based on randomized controlled trials supporting their use for blood pressure reductions and secondary stroke prevention. Although calcium channel blockers are considered a first-line agent for hypertension, there is limited data on their efficacy for secondary stroke prevention. As mentioned earlier, for patients with clinical CVD, blood pressure medications are started when average blood pressure readings are 130/80 or higher. And the answers to the question at the beginning of the video are 1 Bravo, 2 Charlie, and 3 Charlie. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing and sharing my channel. Feel free to leave me some feedback. Thank you. Have a great day.